Good evening, everyone. On behalf of respected Dr.D'Pankar Banerji, sir, Director at the Ideal Fertility Center, Jabalpur, I welcome you all to this clinical meeting, which we are holding on Zoom. And the topic is on infertility. So, without wasting any time, I ask sir to take over and continue this discussion. Thank you.
Good evening, everyone, and it is a pleasure to interact with you on Zoom platform that it gives.
Hello, Dr. Banerji, you are muted.
I was not. Abara. Good evening to all, and this meeting is what I am planning. This is my third meeting with on Zoom platform, and we will be doing twice in a month with journal reading and interesting cases. I request all participants who please be part of this interactive meetings. Give your or present yourself the interesting, difficult cases which you handle, so that it helps us all to grow. This platform gives me an immense advantage to interact with people, doctors from other cities who are referring cases to me, and we can interact with them. So I will be putting a summary of what we are doing today. On summary is, I will be reading two cases, two journal in brief. One in a brief and another effect of ovarian follicle size on oocyte and embryology outcome, little bit detail. I am putting two cases. One is primary amenorrhea, how we handled and how the stimulation has been done, and she got a pregnancy. Another patient is of polycystic ovarian disease with raised BMI and very bad uterus, like with severe adenomyosis. First of all, I am putting this journal of ultrasound obstetrics and gynecology. It is a comparison of antral follicle count and serum antimullerian hormone level for determination of gonadotropin dosage in vitro fertilization. Mind it is in vitro fertilization, but it can be used in IUI also. So whenever you go for any stimulation, now you can depend upon the antral follicle count or serum antimalarial, which is better, and how you can decide the dosage. The ovarian responsiveness stimulation has important implications. Both antral follicle count and antimalarial hormone levels are good predictors. We do the sonographic measurement of the antral follicle count available immediately in most IVF center, and it is not laboratory dependent. Hence, the counting antral follicle is operator dependent and is also influenced by the resolution of the ultrasound. So, little bit it is tricky to do AFC, but AMH is not human dependent, it is a lab dependent. You should have a good lab. The aim was in this paper to compare the proportion of women having a desired ovarian response following ovarian stimulation when gonadotropin dosing was based on AFC or serum AMH level in women undergoing IVF using GnRH antagonist protocol. This is the most common protocol nowadays used. The method was undergoing first IVF cycle, body mass index was exclusion criteria, you can see, and there is a randomization of the people. AMH and AFC levels were measured 1 month prior to the treatment cycle. Patients were randomized to AMH and AFC protocol 1:1, block randomization, block size 10. Now see, the method is patients were randomized to AFC and AMH protocol to decide this initial dose. What should be the initial dose? If AFC is very low, the gonadotropin, they have started with the 300 IU. This gonadotropin, which is given in the paper, is that they used human menopausal gonadotropin along with recombinant, but mostly HMG is being used. It is near about 5 to 15, then gonadotropin dosage reduces, then it is reduces. So accordingly, AFC, they have made this criteria. Similarly, AMH has been used, so you can calculate the dose. This is basically a dose to get at least 6 to 12 oocytes, or if you do IUI, then you should have at least few good eggs. But mind it, if you are doing IUI, this type of dosage will be little bit creating more follicle to be selected, and you have to be very careful of multiple pregnancy. Dosage we are titrated one time only, depending on the treatment response. On day 6, on day 7, they have done a titration. All patients were stimulated according to standardized controlled ovarian hyperstimulation. So there is agonist trigger more than 15 dominant follicle. That means if there is a chance of ovarian hyperstimulation syndrome, there is agonist trigger. HCG trigger less than 15 dominant. Antagonist control cetrelix or ganirelix is used, and gonadotropin is used. One cycle of controlled ovarian, this stimulus oocyte complex previous, one cycle of controlled combined oral contraceptive. This is one of the important things they have done. What we don't do, that combined oral contraceptive we usually don't use, because it might create a change in a response with which like AMH and AFC in previous month we are doing. So this is what I found, that they have also mentioned this may affect the dosing of the follicle. The primary methods is proportion of women having desired ovarian response. Desired ovarian response is retrieved oocyte count more than 6 and less than 40. Secondary outcome is requirement of the gonadotropin dose change, total number of retrieved oocyte, follicular output rate. Planned subgroup analysis, AFC more than 5 or less than 5. This is the result they have shown. No difference was found in the background demographic or clinical characteristic between the AFC and AMH group. So this is the way they have allocated this is the result. It is too much is there, so I'm not going to read it. No difference in the primary outcome. either AFC is used or AMH is used. That means both are used. Increased need for dose adjustment in AMH. If AMH group is being used as a dosage quantification of gonadotropin, if there is less response, then you have to adjust the dose in AMH. Increased gonadotropin dose in AMH. That means AFC gives a better assessment. Lower serum peak estradiol concentration in AMH. Here you can see the number of embryos transferred. Similar number of transferred embryos, ovarian hyperstimulation syndrome cases, clinical and ongoing pregnancy rates. Similar number. When classifying AFC values into low, normal, there was moderate concordance between AFC categorization measured in pre-treatment. When classifying AMH into low, so these are the results, and we can come to the conclusion that results show that there was no significant difference in the proportion of women achieving the desired ovarian response as defined by the number of oocytes retrieved when either AFC or serum AMH level was used for the determination of gonadotropin dose. One of the things they mentioned in this paper is that this AFC, if there is a good machine and good person to do the ultrasound, it day 2 or day 3 gives a very good result in antral follicle count. Because antral follicle count doesn't require any extra expenses. Here, the AMH is possible on the same day, very good. Standardization of the test is must. You have to have a good lab to give an AMH result. These determination gonadotropin dose. The findings are in agreement with those of previous meta-analysis using receiver operating characteristic curve prediction value, according to which both AFC and serum AMH level had comparable performance in predicting the suboptimal ovarian response and excessive ovarian response. Point of discussion, the peak estradiol concentration were lower in AMH group despite receiving the higher total dose of gonadotropin. What are the possible reasons for this? Would it affect the interpretation of finding? AFC and AMH differed from randomization treatment cycle in which way they would bias the result. What are alternatives to block randomization? It is possible for randomization method to influence the result in RCT. This is one paper which I took because most of us, we decide our gonadotropin dosage on AFC or AMH. And AMH is mostly used by gynecologists because we have to be dependent on the AF or antral follicle count sonologist if we are not doing the ultrasound ourselves. But definitely, the things are very easy when you do an ultrasound. Here in this paper, they received priming with combined oral contraceptive pill might create disturbance in the stimulation cycle. Based on both linear and quadratic regression analysis, AMH values 1 nanogram and 3.3 nanogram corresponds with the AFC of 5 and 15 respectively. The aim was 6 to 14 oocytes, and the way they stimulated is same what we do in our clinical practice. All women received GnRH antagonist from 6th day of ovarian stimulation until the day of ovulation triggering. Trigger was done by human chorionic gonadotropin 10,000. If it is follicles are more in number than triptorelin is being used, we use leupride also. And frozen embryo transfer is being used if serum estradiol is too much and there is a chance of ovarian hyperstimulation syndrome in fresh cycle. Women in AFC group compared with those of AMH group received a significantly lower total gonadotropin dose, which we have already mentioned. So this is one paper which I found very interesting and it has been given in Ultrasound Obstetrics and Gynecology journal. The second paper what we have taken is very interesting, and I found this paper very interesting. It is in Fertility, Sterility, and the effect of ovarian follicle size and embryology outcome. Even though we are doing IUI, not doing IVF, we are worried about the embryology outcome or the pregnancy outcome. If there is a good embryology, good embryo formation, blastocyst, then chances of pregnancy will be there. So what we do, we usually do ovum pickup or we stimulate the eggs, ovary. And what is the ovarian follicle size? When we do ovum pickup, we tap all the follicles. Do all follicles contain eggs? Number one. Do all eggs fertilize? Number two. Do all eggs fertilized and they go to blastocyst? Number three. What is the grading of blastocyst on day 5? Number 4, most important. So this paper gives an idea when we do ovarian stimulation, what should be the size of the follicle when we do ovum pickup. During ovum pickup in IVF, we do aspiration of 10 millimeter to 24 millimeter, 26 millimeter follicles. This paper is not with eggs which are coming out from the follicle related to blastocyst formation. This paper is something different, that is size of the follicle, which can be identified while doing the ovum pickup and we can measure it. So very diligently they do this. The objective was relationship between the size of punctured follicle and subsequent embryology outcome. If anybody has any problem of listening or viewing, please raise hand, give your comment. We will take that thing in notice and we will try to amend it. And I request my whosoever we are all interact with me, ask questions so that it will be more interactive. The objective or relationship between the size of the punctured follicle and subsequent embryology outcome. Design was prospective observational study. Setting was private fertility clinic. Total patients 150 oocytes retrieved. Now see, the intervention has been done. Method used to measure follicle was ultrasound. They took 2 X and Y axis. Resulting embryos were group cultured into blastocyst. The groups are made from follicle less than 9.5 millimeter. See how diligently every follicle has been seen, measured, individually aspirated, plus size. Then eggs are identified under microscope and they are group cultured according to the size of the follicle. That is 9.5, 10 to 12.5, 13 to 15.5, 16. You can see up to 25 and more than 28. 8 groups have been made. The main outcome measure was rate of good quality blastocyst per follicle puncture. The study includes 4,539 follicle puncture. See here, there is a difference. That means all follicles they didn't give oocytes. So 2348, 2,348 oocytes. 1,772 mature oocytes, that is M2, and these are bipronuclear oocytes. When they all are exceed 571 good quality blastocysts from 157 oocyte retrieved. Now, rate of good quality blastocysts, see how diligently has been done. This paper is very nice. That 2.2% rate when it is less than 9.5. You can see gradually the rate is increasing at the follicle side, but there is a sudden difference from 14 to 18, then it remains near about that level. That means when the follicle reaches 16 to 18.5 millimeter and we do ovum pickup or give a stimulation or give a maturation injection or IUI also, from here the results are better. Less than 12 millimeters, significantly poor results. 19 to 24.5 mm, significantly better than average. This gives an idea that we can give injections of gonadotropin till the eggs, the follicle reaches to this level. But there is a caveat, there is a problem once, which I will discuss soon. The conclusion is puncture of follicle less than 12.5 millimeter in diameter rarely results in good quality blastocyst. The yield of good quality blastocyst progressively increases with follicle size up to approximately 19 millimeter in diameter, with no substantial decline above that size. Very important statement. The ploidy or the euploidy of blastocyst, they did pre-implantation genetic test for aneuploidy. That form appears to be unaffected by follicle size. That means the follicle size 19, 18, 20, the ploidy rate is same. Prospective observational study of freeze-all cycle. Individual follicles are measured during oocyte retrieval for follicle size and blastocyst correlation. Follicle size rather than oocyte quality is the primary input. Efficiency of oocyte collection, number of oocytes collected per follicle function. When we do egg pickup or oocyte aspiration, there are multiple confounding factors which are working. How is your ultrasound? How is your suction machine? What type? How much amount of suction you are putting? But the previous paper showed that the flushing does not increase the retrieval rate. So we don't do flushing, we do aspiration. Material and methods used were conventional stimulation. Conventional stimulation means from day 2, they have given gonadotropins. Gonadotropin dosage are again decided on AMH and AFC, which we done with everyone. The antagonist 250 microgram of cetro or ganirelix was started 5 to 8 days or E2 more than 400. What we do in our day-to-day practice, we do E2 before LH on day 7 or day 8. Whenever if there is a rise of LH, then we usually increase the dose of antagonist also so that there should not be a premature LH rise. I will show it on board also. The stimulation continues till follicle more than 12 millimeters reached to 16 millimeter at least. The trigger HCG or GnRH analog 4 milligram leuprolide or both, whenever it is required according to the need. Oocyte collection 35 to 36 hours after trigger. During retrieval, each oocyte was measured, recorded and collected oocyte. Each follicle flushed 3 times. Very difficult for us to do this thing, but I appreciate this method to make this paper. Oocytes were assessed for maturity, that is metaphase 2 oocytes and their heat seed. 1 step media global group culture is used with 5% CO2 and 6.5% O2. Media was refreshed on day 3 of culture. Culture was done in blastocyst stage. None with C grade of the inner cell mass or tropoepiderm were retrieved. What is the stage? The stage is if you want to ask anything, you can also ask. This is for egg, and this is the sperm we see, and this is the two cell, and gradually it goes to multiple cells like cleavage stage to morula. Then from day 3 it goes to differentiation, and on day 5 there are cells which are on the periphery, that is zona pellucida, and one group of cells which are collected in one part of this embryo. The embryo on day 5 is called, when it happens like this, called blastocyst. Normally, the blastocyst enters into the uterus in natural fertilization. This inner cell mass and trophoectoderm. According to this Gardner's criteria, A, B, C, D sort of things, and here also ABC. And the dilatation of this blastocyst also being graded. So 5AA is the best. When it becomes C, like the inner cell mass is not good, or trophoectoderm is not good, and it goes to the C category, it is not vitrified. What is vitrification? Vitrification is a method of freezing the thing. Previously, it was slow freezing, but vitrification is a fast freezing. We do vitrification of blastocysts. These blastocysts can be rewound and can be transferred later. I will show the case study when I will show the blastocyst. Relation of body mass index, HNG, how much, what is metaphase 2, the polycystic ovary, these are all tables given in that paper. I'm not going into that detail. The oocyte recovery and embryology outcome has been shown. The discussion is follicle size with good quality blastocyst, oocyte yield 0.622 oocytes per puncture. That is 15 to 21.5 mm. If we aspirate, we get 0.622 oocytes per puncture. That means all follicle puncture don't give oocytes even. The ability of mature oocytes to be fertilized did not differ significantly among follicle size group. Very important statement. That even the fertilization is there. On fertilization, there is a pronucleus. These two pronuclei, male and female, if it is present with two polar bodies, then we can see on the next day that after 16 or 18 hours that it is fertilized. The size of fertilization, the chances of fertilization is same, even from 12 millimeter to 24 millimeter. But chances of being a blastocyst is lesser with smaller follicles. However, rate of development of good quality blastocyst per 2 pronuclei oocyte increased steadily with increasing follicle size. This implies the influence of follicle size on developmental potential is still evident after 2PL stage. That means you can't say on day 1, day 2, day 3 that this happens, so they will go to the blastocyst stage. Chances are less when we aspirate this egg from smaller bulb. So the thing is, what I'm saying is, I don't know whether it will be continued well or not, because there are a lot of first. I have two cases to discuss. One is she is a primary amenorrhea case, and like, बंद कर दें. Unlike, na?
You are
The patient is primary amenorrhea and she is 24 years old, married 5 years. She had amenorrhea, never had periods. Came to us with small uterus with ovary, we did the TVS. And this is the investigation. Karyotype was okay, but FSH and LH both were very low. Please bear with me. Right? Yeah. The FSH is 0.26 and LH is less than 1. So the diagnosis goes in favor of hypogonadotropic hypogonadism. We started Estrabet or estrogen 2 mg BD for 14 days. And endometrial thickness reached 9.97 mm. Then we gave progesterone challenge and then there was a bleeding. We decided to do a hysteroscopy and IVF with own eggs because the couple and the all people, they were asking for egg donation and all, but we asked them and convinced them at least they should have one chance of their own eggs. So they agreed, and now this patient is stimulated. What we have done is that we started randomly, thinking that she might over respond or she might under respond because we have to take a chance. So we started with HMG 300 and recombinant FSH 75, which continued for 1, 2, 3, 4, 5, 6 days. And then we saw on 10th day, on 10th of May 2022, endometrium was 6.9 mm and follicles were there, 4 on the right and 3 on the left. The largest follicle on left side was 11 by 11 and largest follicle on left side is 14 by 10. It was day 2 we started. So this is 2nd, 3rd, 4th, 5th, 6th, 7th and 8th. We have not used gonadotropin antagonist, GnRH antagonist, because the patient is pituitary is not working. So the main thing is, how do we get to know that the pituitary is not working? Yes, that is the main thing where I give this case.
He has never had menses.
She never had menses.
Yes.
And she was married and without knowing, a lot of things happens because there is no menses and still girls got married. And after marriage, there was a problem. And when there's problem, that lot of doctors are, lot of consultation has been done. And because the uterus was chota, ovary was not visible.
So nobody was able to figure out what the
problem
at what level.
Either you take egg from somebody else or adopt. But they convinced by my way of expression and way of explanation that this girl is having, now this is hypothalamus. Hypothalamus and this is pituitary. See what happens with hypothalamus, there is gonadotropin releasing hormone, it comes out from hypothalamus. From which nucleus, I am not going into that detail. When it comes to pituitary, there is a portal system. This pituitary anterior part starts releasing FSH, LH, and lot of other hormones. But these are the two gonadotropins. Why they are gonadotropins? Because they affect the gonads and they stimulate. So they are trophic hormones. They act on this ovary, and this ovary, if you cut it, there are follicles and there are other cells. So this FSH, this LH works on PICA and theca makes androgen. This androgen or androstenedione then percolates into the granulosa compartment and get aromatized
into estrogen.
into estradiol.
Estradiol.
That is estrogen, specifically estradiol. This estradiol is very important for the growth of the follicle, this egg.
Okay.
If estradiol is less, the growth of the follicle will be less and the growth of the egg will be very less. So it will be a small follicle. These small follicles, which there is no estradiol, only egg surrounded by one layer of granulosa cell. These are called primordial follicles or pre-antral follicles. These cells, they secrete AMH. So if AMH is more, then this pool of these type of follicles are more. If these pools of follicles are more, then if you give stimulation, they are recruited more. So you will get more eggs. So better AMH gives better eggs.
Okay.
This is the rationale. Now, in this girl, the AMH was there, but it is 1.27.
Which is low.
Less than 1, we usually say very low, but it is 1.27. That means there is some activity in ovary. But when we measure this FSH and LH, the level of FSH was 0 milli-international per unit and LH was less than 1. Normally, it should be between 4 and 5 to 7, or according to the cycle stage, the LH might go up to 15, 20 also, but near about 5 to 6 if you do in an early part of this cycle.
So for this patient, they were pretty low.
Never had periods. So it is a random estimation of FSH and LH. When we find this trophic hormone of less in amount, that means if there is AMH and there is ovary, and I did this by my interest. We did karyotype also, and this was 46XX.
Okay.
Uterus was there on ultrasound.
Okay.
I can see on transvaginal ultrasound, the ovary is also very small. So I have written this: uterus is very small, ovaries are very small. If this trophic hormone are less, then this factory is not working. So if we can purchase or supplement this FSH from outside, then these factories might work to create eggs and to create hormone, which will affect the uterus. Because the estradiol, which is created from here, will cause proliferative eggs. So when I did this, you can find that.
So by giving exogenous,
This FSH and LH mixture, that is HMG and recombinant FSH,
the ovary started responding.
I put FSH because in early part of the cycle, the FSH is more important than LH, but it doesn't matter too much. The endometrium goes to 6.9 millimeter. That means the uterus also responded, and it was already responded with my sequential hormonal treatment with estradiol, later on progesterone. When it happens, we again maintain that cycle, and the endometrium goes up to 10.8 2 days after. That is on 10th day or 11th day of the cycle, this ejaculation. And on right side, 3 follicle large, 19 by 16, largest. And on left, there are 3 follicle largest, 17 by 14. And we do estradiol, P4 and LH. The estradiol was 266 picogram per ml. Why I did this thing? I always do on the day of trigger mostly, to see how many follicles are growing and how much follicle producing estradiol. If it is more than 250 picogram per ml per follicle, things are okay. The P4, that is progesterone, very important. If it is less than 1, or some book says less than 1.5 nanogram per ml, then the chances of this proliferative phase converting into secretory phase will be less. And if it is prematurely raised at the time of trigger, then the window of implantation will be shifted prior, and we will be getting day 7 sort of endometrium when we do day 5.
Okay.
So chances of implantation will be less. So in this case, if we try to get more large follicles, we have to be very careful that assess the progesterone level. We can increase the stimulation till the basic average follicle goes up above 16, but longer duration of stimulation will create, even though we are using GnRH antagonists, there might be rise in progesterone. If there is a rise in progesterone at the time of trigger, if you are doing IUI or IVF, the chances of implantation will go down. So we have to be very careful about the progesterone. If it is raised, then we freeze all embryos, and we will do frozen embryo transfer. This lady had progesterone 0.42. Again, you see LH, it is again very less. So it is very confusing for me to have LH of less than 1, because at the time of trigger, if endogenous LH is very less, the exogenous HCG injection have to be very perfect, otherwise it will not mature. On 14th of May, we did ovum pickup. We got total 5 oocytes. 4 were mature. ICSI has been done. On day 5, we get one 5AA blastocyst, good quality, one 4AA blastocyst, one early cavity. That means 3 blastocysts of a different, one very good, some were good, and we transferred all the 3. When we see this, this is the best quality blastocyst which is visible, and she got a pregnancy test on 35th of May. One question, okay.
Dr. Yukti is asking which protocol was used, antagonist or agonist, on what trigger was used?
This is very important question, because we are using this in a case where this pituitary is not functioning, the hypothalamus is not functioning. So even though there is a rise in estradiol, there will not be a premature LH surge, because LH is not there. So we don't have any fear of releasing LH. So I don't use, in this case, GnRH antagonist to prevent LH surge. So in this case particularly, because it is hypogonadotropic hypogonadism case, the chances of premature LH surge is less. In next case, what we did, we will show you. So this is the case which we did embryo transfer, and she got a beta HCG of 599.06 million international unit beta HCG. And this is the pregnancy, single intrauterine alive pregnancy. So very challenging and very interesting, and they were very depressed with 5 years married life. She is young and had a primary amenorrhea. So
even with that, she conceived.
She conceived in first attempt.
Yes.
Acha. With this case, we came. This is simple, because the trigger was with HCG 10,000. Here we cannot use GnRH analog trigger, because they are not working. They are not working. If they are not working, then what will happen? If we give GnRH analog trigger, the pituitary is already dormant, is not working. So there will not be release of FSH and LH.
There's no point.
No point. So you have to give an external. The problem was, it would have been a hyperstimulated case. It would have been a problem for us. to give a stimulation. Give us a stimulation because this stimulation will create hyperstimulation syndrome. But fortunately, she did it. So this is one case I discussed.
Gynecologists who are doing IUI, for them, do you suggest doing serum progesterone levels in deciding on?
See, whenever the best method of doing stimulation is getting good quality eggs, either you do IUI or you do IVF. It is ovarian stimulation, controlled ovarian stimulation is same. The point is, whenever we do ovarian stimulation, controlled ovarian stimulation for IUI, we don't want to create too many eggs, too many follicles. Because if we give maturation injection, HCG or anything, there are chances of hyperstimulation, number one, and there are chances of multiple pregnancy. So for IUI, use less gonadotropin to have less dominant follicles. But in these cases, you cannot use anything like chromifene citrate or letrozole because it will work through pituitary. So you have to use exogenous gonadotropin. I should find out the reason why it happened to this girl. What is the problem in brain? What is the problem inside the hypothalamic pituitary axis? The next case which I am putting in front of you is this girl is from Andhra Pradesh, Rajamundry, 36 years old, and body mass index was 31 to 32. She had IVF failure there. AMH was more than 9, and FSH was 2.51, and LH was 6.06. You can make it out 2.0, 2.51, and 6. Huge FSH LH ratio problem. So LH is more. She is mildly hirsute. Ferritin was also low, so we have given this Ferrium injection also. When I did an ultrasound, the uterus was anteverted. She had an irregular period, obviously. Myometrial echo appears severely adenomyotic. So there is a gross adenomyosis. Endometrial echo was visible, it is okay, and ovaries adhered, left well visualized. I cannot see the right. So what we planned, you can see I have made a picture of the uterus. The uterus is like, this is the endometrial echo, and everywhere it is adenoma. It is enlarged bulky uterus. What we planned, I want to see the cavities. So we planned a hysteroscopy, then IVF, then freeze-all, and then frozen embryo transfer. Before frozen embryo transfer, we have to give leupride for 1 or 2 injection before. Well explained to the patient. We did hysteroscopy on 31st of January, and we asked her to come on day 2 of the controlled OA, this combined oral contraceptive pills. When she came on day 2, the E2 was 50 picogram, P4 was 0.28, LH was 5.39, and FSH was 2.7. You can see why we don't day 2 assay, because if estradiol is more than 60 picogram or it is 80 picogram, then chances $60 or $80 picogram per ml. If you stimulate now, there will be no perfect selection of follicle because estrogen is already raised. If progesterone is more than 1.5, I take 1.0 nanogram per ml. If it is more, then previous corpus luteum is work. Now, if you stimulate there will be rise in progesterone and there will be formation of follicle. But if you do a fresh transfer, it will not implant. The FSH and LH, if it is more than 10, it is better to give a oral contraceptive pill another month. This is the basic thing what I do during my IVF practice. This patient was on on February 22, 2nd February, we started this stimulation with HMG 375. Even though the AMH was more than 9, this was little bit more taking a risk, starting HMG 375. And on 7th of February, that means on 7th of day of stimulation, we added cetrorelix, 250 microgram. And on 9th of February, we see the endometrium was 6.65 millimeter. On left, there are 4 follicles. Largest was 15 by 14. On right, there are 2 follicles, 13 by 14. That means even after giving this stimulation, the stimulation was not good. This happens sometimes. We continued the follicle based stimulation, and on 11th of February, we find that 4 follicle, 3 follicle, the largest follicle on the left side was 16 by 17. We continued once again. On 12th of February, cetrorelix was given in the morning. The estradiol was 146, progesterone was 0.25, and LH was 1.16. We decided not to go with fresh stimulation, hence we give trigger of Lupride 30 at 12:39. On 14th, we did ovum pickup. The ovum pickup on 5th day, 20th of February. This was the scene of the follicle, which was where this blastocyst, which is, you cannot say it is 5A, but it is 4AB, or it is a little bit less. Not very good blastocyst, but we have frozen it. On 21st of April, this blastocyst expanded, and there is a collection of inner cell mass, and the quality of blastocyst was a little bit better. So on 21st of April, we did frozen embryo transfer. We prepared the uterus. In between, we used 1 shot of Lupride depot to reduce the uterine size, to reduce the endoadenomyosis, and with estradiol and progesterone, we maintained the we used estradiol 2 milligram TDS for 7 days. On 15th of April, endometrium was 7.32. On 16th of April, the estradiol was 172 picogram per ml and progesterone was 0.82. This is very good report, because if it is more, then we cannot do the embryo transfer. So we decided on 16th April to start progesterone injectable, vaginal, and dihydrogesterone 10 milligram TDS. And on 21st, this is the scene of embryo, which is fairly of good quality in nature. Embryo transfer was easy. We used soft embryo transfer catheter. And on 4th of May 2022, beta HCG came positive. And on 19th of May, you can see this is not a very good picture of, because I have taken from the file. there is a intrauterine fetus alive. This is one, you can see the fetal head and the body. And the beta HCG was done on 4th of May. And the histoscopy we did. And you can see the intrauterine pregnancy also. This one of the very difficult case of getting less follicle, only single egg. With single egg, we did that ovum pickup, ICSI, freeze it, then did a frozen embryo transfer and it gave a pregnancy. So these are the two difficult cases. Today we did, because we have a paper of follicle size and all, I usually go above 16 millimeter, 17 millimeter as far as possible. So one patient we retrieved 22 oocytes today. 18 of them were M2 on day 5. 9 were 5A, 2 were early blastocyst, 2 5A transferred and rest frozen. If you see this case, this is again with the leupride trigger, and we are using this fresh transfer also, not freezing everything, but with fresh transfer, we are using the protocol of luteal phase support of frozen embryo transfer. That is giving progesterone intramuscular, subcutaneous, daily Estrabet in a higher dose, and Leogest or vaginal progesterone 400 mg with dydrogesterone. This gives, let's see what happens, but I will show this embryo also. You can see the blastocyst which we got today. I don't know whether it is visible or not, but you can see a lot of 5AA good quality blastocysts there. This is the inner cell mass. This is tropoectoderm. This is the inner cell mass. This is tropoectoderm. So this is the basic thing we decided today for this journal club meeting. And how many people have gotten?
There is a comment from Dr. Sharda Mishra. Your way of explanation is excellent.
Oh, thank you, Madam Sharda. Thank you. And my request to all listeners who are with me, please be with your good cases so that we can discuss on this forum. On Zoom meeting, you can become my speaker also, and we are planning this meeting twice in a month. We will try to make you aware as early as possible when we follow this. If any question is there, I'm love to answer, because I can go for a 5 to 10 minutes more. Is there any question?
There are comments by Dr. Please have classes more frequently.
This is one of the way I interact, because there are a lot of demand how we do ovarian stimulation. The ovarian stimulation is an art, because you cannot generalize the ovarian stimulation. If you are doing ovarian stimulation for IUI or IVF, always, before this period from where this will be started, do a good assessment. This assessment regarding the female fertility, male fertility, infection, if you require hysteroscopy, whatever it is required. But try to be as far as possible that everything is okay. What is the AMH? What is AFC? If you know these things, then you can manage this case in IUI also, in IVF also, how much gonadotropin to give. The gonadotropins are either recombinant or a good quality urinary HMG also. Mostly they give equal results. These are a little bit cheaper, and sometimes in customized cases we use recombinant donors. If you do IUI or IVF on day second of the cycle, I prefer to do an E2, P4, LH, and FS. You might say it becomes expensive, but the stimulation and the quality of eggs, if E2 is less than 50 or 60 picogram per ml, P4 is less than 1 nanogram per ml, LH less than 10, FSH less than 10, the chances of stimulating and getting good quality eggs will be more, even though you are doing IUI or IVF. In IUI cycles, try to get less dominant follicles. So, if you don't want to use gonadotropins from the day use letrozole. That is 2.5 milligram BD. This can be given from third day to third, fourth, fifth, sixth, seventh, and then to an USG. You can add, if there are selection of 1 or 2 follicles, don't give anything, track it. You can use GnRH antagonist, that is cetrorelix. These things makes your IUI cycle a little bit expensive, but quality-wise gives a better control over the cycle, and you will get a good quality egg on the day when you are doing actual IUI. On the day of trigger, if the patient permits or situation permits, please do again an E2 before at least. This E2 gives an idea about what is the quality of follicle, because more than 250 picogram per ml, at least 1 or 2 follicles are good. If progesterone is less than 0.5 or less than 1, some studies say 1.5 nanogram per ml, then there is good amount or good preparation of the endometrium, and when this embryo gets implanted, it gets an implantation window proper. This is in a natural or stimulated or non-frozen site. But if you want to freeze them, when you do egg pickup over, then what we do, make blastocysts, as far as, even though they are not of 5AA variety, even 4AA, 4AB, I call them a gold medal, a silver medal, bronze medal, even it is bronze medal, freeze it. Then at the time of thawing, sometimes they grow well. Now, people might say that poor quality blastocyst might give abnormal or aneuploid results. It depends upon the quality of the seed, quality of the blastocyst. At present, very less number of blastocysts. I usually don't prefer PGTA at present, but very soon NIPGTA will. But again, there is a caveat. Will this report gives an exact report of the blastocyst? Still no. So whatever the chance patient gets with own blastocyst or own eggs, I transfer. The same thing happens with this Sridevi from south part of India. Only single blastocyst, not good quality, frozen, but gave a pregnancy, and on NT scan, we found that the things are still okay. If they allow, we will do an amniocentesis also, because she is 35, 36. But on double marker and NT scan, we found that is of a low risk. Thank you very much.
I thank everyone for joining here, and it is always good to have Sir discussing various salient points, and we hope to see you in such more meetings. Thank you.
Thank you very much.